part? Okay. And the topic was the relationship between prosthodontics and related disciplines and fundamental to clinical success. I was asked to be lecturer magistralis at that meeting, and my topic then, introducing the meeting, was treatment planning, a multidisciplinary approach. And I selected two cases to illustrate the period of 1980, the year this academy was founded, one which was pre-guided tissue regeneration and osseous integration, and the other after GTR and implants were viable alternatives in treatment planning and periodontal prosthesis in the United States. I therefore selected a case that I felt was a real challenge to represent the period through 1980, in that it represented advanced periodontal disease, many aspects of trauma from occlusion, including severe retrograde wear that was primarily due to external environmental sources. I picked a patient with a flat angle case with a powerful musculature, and nevertheless we'll see the variations on the action upon the teeth. So we see the flat angle, and here we are in rest position, minimal interdisciplinary space. You can see the amount of retrograde wear that occurs on the anterior teeth, and it was found that the patient had a habit, he was milling metal on a lathe and bruxing at the same time. So the anterior teeth suffered severe retrograde wear, and charting shows an unopposed maxillary right second molar super erupted, as it was, as I say, unopposed. And we can see in this radiograph, can I point that out? Is that what you want me to do? Where is that thing? Oh, here we are. Notice the amount of attachment loss, calculus upon the roots, infrabony pocket, and we go to the anterior teeth, which I think we would look upon them as having a rather guarded, if not hopeless, prognosis. And the maxillary left side molars, again, all the signs of infrabony pocket, advanced periodontal disease. Lower right molar, infrabony pocket, and I'm having trouble with this thing. Where are we? Okay. Infrabony pockets present. Lower anterior teeth. Again, an infrabony pocket, which we'll look at for a specific purpose as we go along in therapy. Bite wings, illustrating arch form, relate ovoid arch forms, and first contact in IC. Okay. I'd be better off. Where the heck is that? And in the retreated arc of closure, first contact back on the distal of the lower molar, mesial the upper molar. And we'll see that there's obviously teeth tend to avoid teeth, that this was not active, that the molar was not in contact or interfering in occlusal contact. That larger discrepancy rarely does. Space. And we can see the first contact facet, but notice the absence of any wear here, so demonstrating that this tooth was not disturbing function. Maximum intercuspal position then avoided this tooth. This was a patient in the early 20s, time of his marriage, and we see that he does show signs of a retrograde occlusion, class 2, division 1. And we'll see what happens in 40 years. 20 years, 25 years at the most. And our approach to therapy, of course, was inflammatory control, scaling, replaning, curettage, placing the patient on a very rigorous home care procedure, which his wife carried out for him, and maintenance, which was very critical as far as the continued inflammatory control. And again, the biplane established to apply for occlusal rest. And the patient was a dental phobe and had to be done under IV sedation, which was done in the clinic. Dennis took care of this with Dr. Ruggiero, a member of our staff. And every procedure had to be done with IV sedation, conscious sedation. And following definitive root plane curettage, we then had to go in and reflect flap, make sure that it was definitive, but I'd like to point out, get this, the inner furca area, that the red tissue, in the absence of calculus, is not infected tissue, and we decided we would not clean this out. It would be very easy to scoop this out, but we felt it was critical. That tissue looks similar to what you might see in a guided tissue regeneration re-entry. And we continue, same thing throughout. Again, noticing the lesions. How can I keep that there? Okay, I'm all right.
You're right?
Yeah.
Okay.
And again, based upon the fact that this furca was intact, with the infrabony lesions on the distal of the premolar, mesial of the molar, we're again going to contain that tissue, knowing that we can alter its position. And the lingual, again, notice the furca area. Gee, I wish can't control this. Here. Cleaned out, sutured, and throughout. Now, premolar we considered hopeless. That was extracted at that time. And then careful attention to continued inflammatory control. That's my eye. Early the healing, and then initiation of tooth movement and eruption. But notice the condition of these tissues. A graft had been placed here. And we're now ready to proceed with the restorative aspects of therapy. So the teeth are prepared for a full arch provisional restoration. At that time, the anterior teeth were removed first by sectioning them, so we wanted this little interference with the provisional restoration, and after visual restoration was carried over, the roots were removed. Now we fit copper bands, since we're no longer able to get gold bands. This is 1980. And the teeth were prepared and provisionals made, block carving used in the posteriors. And lower anteriors, and establishing the provisional, including the provisional state. And then after evaluation, taking impressions, plating our dies, making our transfer copings. Notice the size of the tongue, incidentally, which was also a problem. And the transfer of bite relationship, inner arch. Face bow utilized here is a maxillary orientation. It's not a hinge row. And final castings made, assembled in the mouth, centric checks taken, and we can see the condition of the tissues. And I'd like to quote a statement made by Frank Salenza, who was a dyed-in-the-heart, bilateral balanced nephrologist, going that first to disclusion, and then to the fact he made a statement that I thought was very critical. The precision of the position is more important than the position itself. Meaning that we have to have an absolutely positive posterior maximum intercuspal position. Very, very critical, and I think to any case. And just final restoration, then transferred into porcelain, which also a departure in 1980. And then we'll follow the case and healing. Above you see the pre-op, post-operative. The other side, the pre-op. This little arrow. Post-operative, where we had re-entered. Here, pre-op. Post-operative. And that lower molar I suggested we were to follow. This was with tooth eruption, infrabony pocket, and it's post-op. Again, of course, maintaining scaling, root plane curettage, and good plaque control as this occurred. Tears. And pre and post-op. Radiograph TMJ, and also your Ceph 1980, 1992. So in evaluating the response of this case and showing what we were able to achieve by following our basic precepts of inflammatory control, occlusal therapy where necessary, and then careful maintenance. Incidentally, the plaque control in this patient was actually accomplished by the patient's wife. And I know that this patient survived until 1998, in which he passed away. But his wife comes in. It's really funny. My housekeeper recognized his face and named him. A good friend of hers, so I had checked on him. That's how I checked it. Going on then to what we might see in latter part of the 80s and into the 90s, and what we are seeing today, of course, is the introduction primarily of implant prosthesis, which I think is one of the great contributions to dentistry, the fact that we now have a truly implant-capable of osseous integration. If properly used, it adds much to our therapeutic endeavor. However, it is a tool and not a concept in dentistry as far as I am concerned. I'm going to show another case done in the clinic. This time, I think everybody was involved with this young gentleman who was from Taiwan, Youngmin Cheng. I think it was treated by both Arnie Weisco and myself, or monitored. He actually did the treatment, and Dr. Henry Salama. Patient, 50-year-old female, front teeth are loose and separated, lateral, allergic to coating. She was a smoker, which we have to hold her, and her attitude was very cooperative. See that she also is a deep overbite with mobility and posterior collapse. Again, looking back, earlier period in her life, we see that quite a change has taken place. And I think it's important we understand that as we treat people, that throughout life they are different people. That there's a saying that we are never standing in the same river twice. And we have to understand that as we go on in therapy. So here she is as of today. Collapse. And again, you see less involvement periodontally with posterior collapse and flaring of the anterior teeth. And she is a class 2 Div 1, Division 1. She's skeletal as well as dental. And the treatment plan then, again with inflammatory control, and evaluating the response of that patient to inflammatory control. And then we can look at the occlusal factors involved in the case. I go through that. Also, you can see the action of the tongue. Where's that little thing? Okay, right here. Ulceration, the fact that an active tongue habit that has to be controlled. And the diagnosis in this case, again, was moderate adult periodontitis with localized advanced loss of attachment. Posterior bite collapse, flaring out of upper and lower anteriors, and loss of vertical dimension. She's a class 2 Div 1 with adult tongue thrusts. Possible periendo combined lesions 17-18, number 31 and 32. Inadequate zone of keratinized gingiva, hypersmentosis, and root canal 10 and 11. Etiology again, dental plaque and calculus, posterior bite collapse due to tooth loss as a result of caries. An important distinction between teeth that are lost due to caries and teeth lost due to periodontal disease as far as establishing a prognosis. Parafunctional habit including tongue size and thrust. Inadequate periodontal support. And the overall prognosis depends on whether or not the parafunctional adult tongue thrust can be controlled or at least tempered. And individual prognosis can only be evaluated after response to inflammatory control and the patient's attitude and cooperative ability in home care. And just evaluating before and after initial therapy, if you want to call it that, we prefer calling it primary therapy. We want to provide good periodontal care and maintenance to correct the malocclusion, establish therapeutic occlusion, and to correct the ridge defect and replace the missing teeth, restore arch integrity, function, and aesthetics. And I might say that our concept of a therapeutic occlusion is one which creates occlusal stability, is self-cleansing, and amenable to ancillary means of home care. Using that as our objective, it takes us away from a lot of various concepts of so-called occlusal therapy. And just a model setup. And once we are going to make major changes, we prefer that in most instances that a trial setup is done on the model, establishing the type of occlusion that you would like to see established in your therapeutic result. And notice that the posterior teeth molars, lower molars are to be removed, and the posterior occlusion will be partially supported by implants and combination. And the implant therapy here is to help establish the occlusal vertical dimension and provide anchorage for tooth movement. Hopefully, if we place early implants, that we have carefully surveyed the case so those implants can be used not only for tooth movement, but can be used as a final restoration. Orthodontic therapy being done to correct the malocclusion, site development for the implant placement, both the soft and hard tissue, and decision-making for optimal implant position. And implants are placed, and beginning using them for anchorage and going on to the orthodontic movement, we're going to do eruption, maxillary anterior teeth, and intrusion, retrusion of them, which we hope will bring down the hard and soft tissues and set up the case for final restoration. Notice the aesthetic improvement with the repositioning of the anterior teeth as opposed to what we have here. And setting up again the tissues for placement of the implants. And provisional restoration made. So we see the same sequence of therapy is maintained, except we have the added use, proper use, I think in this instance, of the implant to establish posterior support. And what we'd like to see, of course, the occlusion maintained by posterior support, and then the anterior teeth functioning for disclusion. And here we are going to have an implant support and assisted restoration. I think you were involved in this, Henry, right?
Yep.
And your socket. And there was an attempt in one instance to retain one root in order to preserve the osseous architecture, hopefully to prevent its being resorbed. So we see the before models, one of my contributions. Stable occlusion in the models, exactly as was planned. Your radiographs showing you an implant supported and assisted restoration. And I might point out the one root Where the heck is that thing? Where are we? Oh, got it. Submerged in an attempt to maintain the alveolus, and that lasted for quite a while, but ultimately was resorbed. Right? Final radiographs. Remember this? Sure. And models before tooth movement and after, and the patient quite different. So we saw again the blending of the age of aesthetics as we exited the age of Aquarius. And our common thought for success between the multidisciplinary aspects of perio first, orthodontics and prosthetics in most of the cases, and of course some also may require endodontics. I'm sorry. And this is our real model, right? The right tools for the right therapy at the right time for the right patient. If we screw any of this up, we can be in trouble. You may have the right tools for the wrong therapy, or realizing the nature and the patient you're dealing at that particular time. It has to be the right patient, and a patient who really understands and is cooperative. And based upon that, we can usually have predictable success. And the one thing that we can say is that implants have possibly modified our treatment plan in certain instances, but it doesn't alter our respect for basic therapy. Okay? All right? Okay. You want to see this? Wait, I'll show you. That's the clinic that I practiced in, Henry. Mm-hmm. Had little lights, chairs, and then we redid the clinic in 1961, 63 when I put in my modulation. It's not going to do it again, I hear. And then
you know what? That's where I did my undergrad in that clinic, but with the better equipment.
Oh yeah, before the breakup. Yeah, but the equipment was totally chairs, lights. That was a modular unit you used, same as the Myers clinic. Yeah, that's
1950.
That's when it was built. Yeah, that's when the school was built here. That was built on Thomas Evans' home property. It's a beautiful structure.